Morning to all of you. Once again, welcome to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a class on immunotherapy in bladder cancer. We all know immunotherapy recently is coming in a big way in various urological cancers. So today we are going to discuss its role in bladder cancer. And our resident, Dr. Prashant, is going to present, and it will be moderated by our faculty, Professor Neeraj Agarwal. So Neeraj, kindly take over and invite the presenter, please. Go ahead.
Good morning to you all, and thank you, Shivam sir. Today's webinar is on a very interesting topic of immunotherapy in bladder cancer. A lot of really exciting advancements have been made in the treatment of metastatic and locally advanced bladder cancer. And one such development is immunotherapy. To deliberate more on this topic, I invite Dr. Prashant Sevach to present his seminar. Over to you, Prashant.
Good morning, respected teachers, seniors, and colleagues. I am presenting a seminar on immunotherapy in bladder cancer, moderated by Dr. Neeraj Agarwal sir. Immunotherapy is use of medicines to help a person's own immune system recognize and destroy cancer cells. Types of immunotherapy are intravesical BCG, cytokines, immune checkpoint inhibitors, monoclonal antibodies. Coming to intravesical BCG. BCG is an attenuated strain of Mycobacterium bovis. In 1929, Pearl proposed anti-neoplastic effect of tuberculosis infection. In 1976, Morales first described intravesical instillation of BCG. In 1980, Lamb confirmed the efficacy of intravesical BCG for prophylaxis. Mechanism of action of BCG. The initial step is direct binding to fibronectin, thereby stimulating cell-based immunologic response. It results in induction of T helper type 1 response, thereby release of various cytokines like tumor necrosis factor alpha, granulocyte macrophage colony stimulating factor, interferon gamma, and various interleukins like 1, 2, 5, 6, 8, 10. For BCG instillation, it is done 2 to 4 weeks after tumor resection so as to give time for reepithelialization. Otherwise, there is risk of intravasation. Before instillation, urine analysis and culture is performed to rule out infection or hematuria. If traumatic catheterization is present, then it is delayed for a few days. Before instillation, restriction of fluid and caffeine intake is done so as to prevent dilution and make patient comfortable to hold BCG for 2 hours. Technique. Patient is asked to empty the bladder. Catheter is inserted gently without traumatization. Dose of BCG 120 mg reconstituted in 50 ml saline. And filling is done with gravity. After patient is asked to change his position and asked to hold urine for at least 2 hours. After it, patient voids and flush the toilet with disinfectant. In induction phase, BCG is given intracyclically once a week for 6 weeks, followed by maintenance phase, that is once a week for 3 weeks, at 3 months, 6 months, and then every 6 monthly for 3 years. In patients with intermediate and high risk non-muscle invasive tumors, intravesical BCG reduces the risk of tumor recurrence after TURBT, and it is more effective than TURBT alone or TURBT and intravesical chemotherapy. A 3-year maintenance is more effective than 1-year maintenance to prevent recurrence in patients with high-risk tumors. There are some contraindications to BCG therapy. Absolute contraindications are immunosuppressed or immunocompromised patients, not given immediately after transurethral resection, with a personal history of BCG sepsis or traumatic catheterization of gross hematuria, or patient is incontinent, as he might not be able to retain the agent. Your relative contraindications are UTI, which may increase the intravasation risk of BCG, or liver disease, which will preclude the treatment with isoniazid if sepsis happens, or personal history of tuberculosis, advanced age, or poor overall performance status. General intravesical BCG therapy complications, most common is irritative bladder symptoms, and followed by hematuria, low-grade fever, nausea, malaise. Due to BCG toxicity, it is divided in three categories. Category 1 is mild or moderate irritative voiding symptoms, mild hematuria or fever less than 38.5 degrees Celsius for less than 48 hours. Urine culture is done to rule out bacterial UTI, and symptomatic treatment is given with NSAIDs, analgesics, or anticholinergics. In category 2, symptoms are severe or lasting for more than 48 hours. In urine culture, chest radiograph, liver function test is done. Isoniazid and rifampin is administered orally until symptoms are resolved. Vitamin B6 or pyridoxine is given. Consider dose reduction to 1/2 to 1/3 of dose when instillations resume. Treat culture as appropriate. Can also consider pre-treating with single dose of isoniazid before each subsequent instillation. Do not use monotherapy. And also observe for rifampin drug interactions with warfarin, as it decreases half-life. Therefore, dose of warfarin might be required to increase. In serious complications like hemodynamic changes, persistent high-grade fever, allergic reactions like joint pain, rashes, or solid organ involvement. In treatment, we have to give isoniazid and rifampicin depending on response. Vitamin B6 pyridoxine is given. Can also add ethambutol. Pyrazinamide has no role as BCG is almost uniformly resistant to pyrazinamide. BCG instillations are stopped. Prednisone may be considered if response is inadequate or in case of septic shock. Coming to cytokines, it includes interferon like interferon alpha and interleukins like mainly interleukin 2, interleukin 12. Interferons are regulatory cytokines produced in response to antigenic stimuli. They have multiple anti-tumor activities. They do T and B cell activation as well as have natural killer cell activity. Among interferons, interferon alpha has been most extensively studied. It is most active in doses of at least 100 million units, although optimal dose and administration schedule has yet to be determined. As a solitary agent, interferon is more expensive and less effective than BCG. However, it can occasionally be effective in patients in whom BCG has failed, as 15 to 20% complete response has been seen in few studies. It is more effective as a combination therapy with BCG than alone, and combination therapy is superior to BCG alone. The main benefit of combination therapy with BCG is it helps in reducing the BCG dose without compromising the efficacy of resin. Interleukin 2. It is highly expressed after BCG stimulation and key component of T helper 1 immune response. Intravesical instillation of interleukin 2 induces long-term T cell memory against bladder cancer. Combination therapy of BCG, intravesical interferon alpha B, alpha 2B, and interleukin 2 have shown high response rates in patients who have failed intravesical BCG therapy. Coming to interleukin 12, it is delivered along with chitosan, a mucoadhesive polysaccharide. It helps in increasing the absorption of interleukin 12. Animal studies have indicated efficiency of 90%, and they have shown that creation of specific immune memory that protects against recurrence. It stimulates macrophages to release interferons, thereby leading to activation of T helper cells. It also decreases the number of regulatory T cells and suppressor cells. Clinical trials are not yet available for interleukin 12. Now, important topic, immune checkpoint inhibitors. PD1, that is programmed cell death protein 1, and PDL1, programmed cell death protein 1 ligand 1. PD1 present on T cells and PDL1 present on antigen presenting cells. They are part of immune system checkpoint, and they negatively stimulate immune response. So when they are inhibited, it results in immune system activation, thereby facilitating the killing of tumor cells. PD-1 binds to PD-L1, which blocks the activation of T cells, thereby reducing the production of interleukin-2 and interferon gamma. This promotes self-tolerance by preventing the immune system from indiscriminately attacking the cells of body. But it also stops the immune system from attacking cancer cells that express PD-L1. So PD-1 or PD-L1 inhibitors are antibodies that block these two molecules, thereby cancelling the checkpoint activity and resulting in T cell activation, thereby having the cytotoxic effect on tumor cells. FDA have approved currently 3 PD-L1 inhibitors and 2 PD-1 inhibitors for bladder cancer treatment. First is atezolizumab. It was the first PD-L1 checkpoint inhibitor approved by FDA and EUA as second-line therapy for advanced bladder cancer patients. It is recommended for patients with advanced or metastatic disease in whom treatment with platinum derivatives has been ineffective. Avelumab, second PD-L1 inhibitor approved by FDA in 2017. The results of phase 2 trial showed that avelumab induced persistent anti-tumor response in patients with advanced bladder cancer whose tumors progressed during or after platinum-based chemotherapy. Durvalumab, approved by FDA in 2017, studies in phase 1 and 2 patients have confirmed effectiveness that 20.4% of patients showed immune response to drug and around 5% showed a complete response. Activity of this particular drug is high in PD-L1 positive and negative patients, but higher responses were noted in patients having high PD-L1 expression. Nivolumab, approved by FDA in 2017 and by EUA also, a phase 2 study was conducted in patients with advanced bladder cancer and a median overall survival was 9.7 months with an annual survival of 46%. There was no significant difference among patients with PD-L1 overexpression. In addition, 59% reported adverse drug reaction with 10% having serious adverse events. Pembrolizumab. It is approved by FDA and EUA based on the ongoing phase 3 trial. It may induce immune-related adverse effects such as myocarditis and myasthenia gravis, but they are seen to be of mild intensity. It was the first immune checkpoint inhibitor that showed significantly better overall survival than chemotherapy in few studies. Some recommendations related to advanced bladder cancer patients. Regarding first-line treatment for platinum-fit patients, use of cisplatin-based combination chemotherapy with gemcitabine cisplatin or high-dose intensity methotrexate, vinblastine, adriamycin plus cisplatin has strong recommendation. In patients unfit for cisplatin but fit for carboplatin, combination of carboplatin and gemcitabine is strongly recommended. And in patients achieving stable disease after first-line platinum-based chemotherapy, maintenance treatment with PD-L1 inhibitor avelumab has strong recommendation. For second-line treatment, checkpoint inhibitor pembrolizumab to patients progressing during or after platinum-based combination chemotherapy for metastatic disease has strong recommendation. Offer antibody drug conjugate and enfortumab as monotherapy to patients with advanced or metastatic bladder cancer who are pre-treated with platinum and immunotherapy has strong recommendation. This flowchart for management of metastatic urothelial cancer. Patient is divided into platinum eligible and ineligible patient group depending on the GFR and performance status. The GFR more than 50-60 cisplatin is preferred 4 to 6 cycles of gemcitabine cisplatin. If cisplatin is cannot be given, then carboplatin is preferred in place of cisplatin with gemcitabine. If in case of progressive disease, second-line therapy with pembrolizumab is given. In platinum ineligible patients, immunotherapy with atezolizumab or pembrolizumab is given. Later line therapy is monoclonal antibody like erdafitinib or patient may be enrolled in trials. is a review regarding immune checkpoint inhibitors for metastatic bladder cancer 2018 March, which stated that atezolizumab and pembrolizumab showed in phase 2 and 3 trials to improve clinical outcome of patients who progressed to platinum-based chemotherapy. However, atezolizumab failed to show overall survival benefit over chemotherapy in phase 3 trial for patients progressing to platinum-based therapy. It stated that immunotherapy improved clinical outcome of patients who are unfit to first-line platinum therapy. These are certain landmark trials using immune checkpoint inhibitors as second-line therapy in advanced bladder cancer. With the Keynote 45 trial studied pembrolizumab 200 mg IV 3 weekly, and it was FDA approved in 2017. Javelin solid tumor trial study avelumab and Checkmate 275 trial study nivolumab, and all were FDA approved in 2017. Certain landmark trials using immune checkpoint inhibitors as first-line therapy in advanced bladder cancer. Among these, the Javelin Bladder 100 studying avelumab showed improvement in primary endpoint, that is overall survival, and it was FDA approved for maintenance therapy in 2020. Select certain phase 3 trials using immune checkpoint inhibitors as adjuvant therapy for muscle-invasive bladder cancer was also studied, in which Checkmate 274 met primary studied nivolumab versus placebo and met primary endpoint of disease-free survival and was FDA approved in 2021.
That primary endpoint in FDA approved 21. So what was the primary endpoint?
Sorry, disease-free survival was the primary endpoint, and it showed 20.8 months disease-free survival in nivolumab arm versus 10.8 months in placebo arm. This is a diagram showing evolution of immune checkpoint inhibitors, which started from 2015 with atezolizumab and progressed subsequently with nivolumab in Checkmate 32 trial, pembrolizumab in Keynote 52 trial, with Javelin trial having avelumab, and subsequently all were approved by FDA as second-line therapy for metastatic urothelial carcinoma, with atezolizumab and pembrolizumab also getting approval as first-line therapy for metastatic urothelial carcinoma in cisplatin-ineligible patients. This is a table showing response rate and median overall survival with FDA-approved immune checkpoint inhibitors in metastatic bladder cancer. For metastatic second-line therapy, pembrolizumab showed 10.3 months overall survival, Belmont et al. In phase 3 trial. Nivolumab showed 8.7 months overall survival in phase 2 trial. For metastatic first-line therapy, atezolizumab and pembrolizumab were recommended, with atezolizumab showed 15 months overall survival in phase 2 trial, Bladder et al. This is platinum-ineligible patient. Coming to anti-CTLA-4 antibodies, cytotoxic T lymphocyte-associated protein 4. It is a surface molecule which is expressed by activated T cells. It is a co-stimulant which is necessary for activation of T lymphocytes. It negatively regulates immune response, but exact mechanism of action is not yet fully understood. Its inhibition may increase the regulation of immune response to bladder cancer. So this is the underlying hypothesis behind ongoing research into it. Ipilimumab is anti-CTLA-4 antibody developed by Bristol Myers Squibb. It is used for treatment of melanoma and used in combination with nivolumab for the treatment of advanced RCC and metastatic colorectal cancer. Garten et al. Investigated its safety and found a tolerable safety profile. Studies are in progress on combining ipilimumab with immune checkpoint inhibitors. Tremelimumab, anti-CTLA-4 antibody being investigated in combination with durvalumab It has not yet been approved by FDA. In a study conducted on 18 patients with advanced bladder cancer, most of the side effects were mild, but one died of intestinal perforation. More research is needed on the way this drug works and its effect on patients. Monoclonal antibodies like enfortumab vedotin. It is an antibody drug conjugate that is a monoclonal antibody linked to a chemo drug. Bladder cancer cells usually have Nectin-4 protein on their surface. Enfortumab is anti-Nectin-4 antibody attached to a chemo drug. So this antibody acts like a homing signal, bringing chemo drug to bladder cancer cells with Nectin-4 on them. After attaching, chemo enters the cancer cells and kills them. Sacituzumab govitecan, it is also antibody drug conjugate. It attaches to TROP2 protein on bladder cancer cells, thereby bringing the chemo directly to them. It can be used in people with advanced bladder cancer who have already been treated with platinum chemo drug and immunotherapy. Limitations of immunotherapy is effect is of immunotherapy is influenced by immunity of the patient. So it has no role in immunosuppressed or immunocompromised patients. Intratumor heterogeneity of tumor neoantigens, mutation, tumor cell mutation target, and tumor mutation load have significant effect on its therapeutic effect. They can produce negative regulation, thereby leading to autoimmune diseases, which may lead to death. Treatment costs of immunotherapy are high. Some future perspectives like mTOR kinase inhibitors, everolimus or sirolimus, they bind to FKB12 protein, thereby forming a complex that inhibits mTOR activity. It results in cell cycle arrest and inhibition of cellular proliferation. Efficacy of everolimus have been well documented for bladder cancer treatment in vitro and in animal studies. In vitro studies have shown the effectiveness of everolimus combined with cisplatin, but more research is required for it. One COX-2 inhibitor, celecoxib, it is selective COX-2 inhibitor that has chemopreventive activity. It inhibits proliferation, migration, invasion, and epithelial to mesenchymal transition of bladder cancer cells. So it can be a future prospect for treating bladder cancer, and studies are going. The take-home message is intravesical BCG is more effective than TURBT alone or TURBT and chemotherapy in non-muscle invasive bladder cancer. BCG is contraindicated in case of disrupted urothelium. Interferon is more effective as combination therapy with BCG than alone and has benefit of reducing BCG dose without compromising its efficacy. Platinum-based chemotherapy is first-line treatment for advanced bladder cancer. Immune checkpoint inhibitors are second-line treatment for advanced bladder cancer. FDA has approved 5 immune checkpoint inhibitors with atezolizumab, avelumab, durvalumab, nivolumab, pembrolizumab. More research is required for regarding anti-CTLA4 and monoclonal antibodies in bladder cancer treatment.
Yeah, thank you, Dr. Prashant. So now I would request Dr. Neeraj, please go ahead with your comments and if you want to add something. Yes, Neeraj. I think there's some signal problem with any queries from the residents or any faculty member. Nachiket, yes, Neeraj, your audio is not on. Audio chalu. We cannot hear you. Nachiket, you would like to say anything?
Sir, I wanted to ask him. Then now with so many molecules which are receiving FDA approval, you said that there are 5 molecules. So which of it seems to be the most promising in advanced?
The pembrolizumab. Pembrolizumab.
That seems to be the most promising.
Yes.
What is the dose? How do you expect
Is it available for commercial
Yes,
use?
it's available for commercial use.
इंडिया में आ रही है कि नहीं So no, the point is valid that when you present something, you should know exactly about the whole thing, and then even the drugs that are being used, whether they are available in our country, can we use it in our own clinical practice or not? That is again very important. So try to learn all these things and come prepared in the class. Yes, Neeraj, would you like to say?
Sir, I think, yes, sir. So can you hear
Yes,
me
go
now?
ahead. Yes, go ahead.
So I think, sir, pembrolizumab is commercially available in India.
Yeah.
And it is given as an IV infusion. And the standard dose is 200 milligrams IV infusion. And it has to be given every 1 week to 2 weekly as an IV infusion. As far as the cost of therapy is concerned, I think it's in the range of about 3 to 4 lakh rupees a month. So the cost is quite prohibitive at the moment.
Right. So most of these probably in our country is they are part of the clinical trials which are going on with different ICI immunocheckpoint inhibitors, and only those who really can afford it would be able to do it, or probably now with the insurance scheme, some of these immunotherapies may be part of the insurance scheme also. So I am not very sure whether in Ayushman Bharat or Chiranjeevi we have immunotherapy available or not. But maybe in the near future we may have this available in our insurance schemes. Anybody else has anything to say? Yes. Yes.
Sir,
Yes, Neeraj?
till recently, sir, these immune checkpoint inhibitors, they have been mainly indicated in patients who have failed to respond to cisplatin-based chemotherapy. So they have been mainly used as second-line agents after failed chemo. But
Exactly.
as of now, various recommendations and various guidelines are coming. They can be used even in superficial bladder cancer, a thing which I think Prashant did not mention. In non-muscle invasive bladder cancer patients who are BCG refractory or BCG unresponsive, they are being used as first-line agents, especially pembrolizumab, in superficial bladder cancer. That was number 1 point. And number 2 point is, even after chemotherapy, patients who have responded, they can be used for maintenance therapy. Even if a patient responds, it has been observed that if you give these immune checkpoint inhibitors after a stable response to chemo, it prevents your overall progression-free survival as well as your overall survival. So these are the 2 points that I wanted to make.
Right. Dr. Adi has something to ask. Yes, go ahead.
Any receptor study or any study of the human is required to start IC inhibitors?
In clinical setting?
Yeah.
No, I don't think any receptor study has to be done before starting any immunotherapy.
So, they can study about the status of PD-L1 and PD-1 status, but since the studies in trials, so they give both. Yes.
So there, like in carcinoma prostate, also you study the tissue biopsy and find out the various receptors. Like even CA breast, also you try to find out the receptors, estrogen, progesterone, and human epidermal growth factor receptor HR2. So do you have something similarly that you need to see the biopsy for the presence of receptors?
PD-1 and PD-L1.
I think so. So that's a good.
Immunohistochemistry. You do immunohistochemistry on the tissue sample and check for PD-1 and PD-L1 receptor status. Unfortunately, sir, one of the concerns here is that there is a quite variation in the response rate. Patients who are PD-1 positive or PD-L1 positive, they may fail to respond to these immune checkpoint inhibitors. So there is quite a heterogeneity in the tumor receptor status. Some patients respond, some patients don't respond. So as of now, there is an ongoing search to identify more and more receptors on which these drugs may act. As of now, we have, I think, only PD-1 and PD-L1 receptors.
Yeah. So PD-1, PD-L1, and the other one is the CTK, A4. Right.
A4.
So what is PD1
Programmed cell death protein.
and L1?
Programmed cell death protein ligand.
Ligand 1, right. So, so do you know when did this immunotherapy start? Started at what time in the history?
Sir, its evolution started in 2015 regarding
No, not. I'm not talking about ICI. I'm talking about immunotherapy. Anybody? So, at the first thing was in 1890. One colytoxin bacterial protein was derived from one of the bacteria, and that was being used as an immunological agent. And then after till I think the BCG came, which was in 1976 and then 80, there was no other immunotherapeutic agent. And then interleukin 2 and interferon came in the 90s, and now we have these immune checkpoint inhibitors and other various immunotherapies. What other immunotherapies you know of besides ICI?
Monoclonal antibodies, which are conjugated to specific chemo drug.
Yeah. And
certain cytokines like interferons, interleukins.
Right. And there are certain vaccines also available for various malignancies. Right. These are also part of immunotherapy. Right. And what is the future? In future, what could be the advance in the treatment of bladder cancer or any urological cancer?
So from future perspective, immunotherapy
is one play a major role besides immunotherapy.
COX-2 inhibitors like celecoxib, which has been seen to have effect on preventing.
So again, it's a part of immunotherapy. Yes. Anything else?
mTOR kinase inhibitors.
Yes, that is again part of it. Immunotherapy.
So one of the things that they are studying.
Yes, pardon.
One of the things that the ongoing research is going on is on combination of immunotherapy. So as of now, there are various trials are going on combination of pembrolizumab and avelumab. And it has been seen in the initial phase 1 and phase 2 studies that combination therapy is found to have a better response rate, although the toxicity profile and all those are issues, but the overall response rate has been better. And the second thing ongoing trials are studying is the combination of immunotherapy with chemotherapy. So they are using cisplatin-based chemotherapy along with pembrolizumab in the locally advanced metastatic bladder cancer.
Right, you are right. So a lot of combinations are being tried, and the first combination that we tried was with intravesical BCG plus mitomycin, right? But that combination proved to be not very good when you compared with intravesical BCG alone, because intravesical BCG alone was less toxic and equally efficacious. So it was not continued. But now we are trying a lot of other combinations for these patients. So gene therapy could be one of the treatment option in the future. Then there are stem cells also being used for various urological cancers. I think this is probably the future of all, particularly metastatic urological cancers. In general, all cancers, probably. So I think we can wrap up the session. Dr. Neeraj, please give your last comments and then we'll wrap up.
Thank you, sir. And my apologies, sir. I could not join physically because of some personal reasons. So anyway, thank you, Prashant, for the nice presentation. And I think it's primarily this immunotherapy has been prescribed by medical oncologists. But I think we treat and see more patients of bladder cancer than these oncologists. And as urologists, we should be at least aware of what the latest developments in immunotherapies are, even if we don't, prescribe them or give them routinely. So your seminar gave us an insight on to the latest immunotherapies that are being used. Thank you, Prashant, and thank you, sir. Thank you.
Thank you. Thank you, Neeraj. Thank you all residents and faculty, those who have joined us today, and have a good day.